is a 75-year-old patient who had about 7 years history of pain in the back and radiculopathy that is practically everywhere. It's front of the thigh, side of the thigh, back of the thigh, which correspond to all the dermatomes from L2 to S1. Now, obviously, this patient has exhausted all non-surgical treatment, including physical therapy, bracing, and the symptoms are over the time are getting significantly worse to a point that patient has been non-ambulatory, bedbound for 6 months before even patient comes to me. And at the time patient comes to me, she's reporting to me that she has been really deconditioning rapidly, meaning that she's not able to walk, and she has actually lost about over 40 pounds just in 3 months. She's barely 50 kilograms, and she's overall in not a great condition. And but which has something to do that she's not been walking partially, but as well the fact that she's compromised cardiovascularly and overall in health compromise is makes it really hard for some other surgeon who has seen the patient give the patient the option of the surgery. Practically, this patient has seen 2 other spine surgeon, very good surgeon locally, all of which have told her that there's no way she can have a surgery. And I'm actually now available to give you all clinical information that you have. If you have any clinical question for me, you can type it in the chat window or unmute your microphone and just ask me. So I'm happy to answer your all questions. Patient has throughout weakness in both lower extremity, but mostly the weakness seems to be in tibialis anterior and actually hamstring, but throughout patient has significant weakness. So first of all, what other question do you have for me at this point? What else would you like to know about this patient? This is just one picture, but I'm going to actually open some other films that we have obtained in our facility and show you as well some other pictures about this patient. But so far, what question do you have for me? So I'm actually opening the other pictures that this patient has, but but I'm happy to answer if you have any other question. I'm happy to answer it right now.
Dr. Abbasi, does this patient had any paralysis in extremity?
Weakness. Patient does have weakness. Mostly 4 minus of 5 in the tibialis anterior and 4 minus of 5 in the left hamstring. But the patient is throughout weak. She has not been walking for almost 6 months, and practically she's overall very weak in almost all segments in the legs. But yeah, any other question regarding and again, this patient has gone through years, has done physical therapy, has done all the non-surgical treatment, and including bracing, injection, multiple bouts of radiofrequency ablation, and all of that obviously has been very, very little helpful to this patient. And that is why the patient actually coming to us, because 2 other surgeons, based on overall patient symptom, has told her that she cannot have any surgery at all. So if there are questions, I'm absolutely happy to answer them. If there are no questions, I'd like to just go over the patient pictures with you right now. Just look at some of the pictures with you. And again, if I'm missing to admit somebody, and you notice somebody is in the waiting list and need to be admitted, please let me know. So I am actually going to share my screen here with you.
Dr. Abbasi, Somaya has a question
Absolutely.
in chat box. In chat box.
Okay, let me see. Do you mind to read it for me, sir? What is your thought about scoliosis or spinal tumor? A spinal tumor regarding so, well, obviously in this case, we have done full diagnostic. It's not a spinal tumor. And but tumors and scoliosis, they can be incidental, that people with scoliosis may have a tumor and vice versa. The tumor may weaken bone structure, cause or add to scoliosis. I think if somebody has spinal tumor and scoliosis, the plan has to address both of them. Like if the tumor has to be resected, your hardware have to compensate for the deformity that already there and you will produce with the resection of the tumor. In this specific case, we have done full diagnostic and this is not a tumor case. But I'm going to now actually, share the three views of the spine with you on this patient. So let's see where we are. So are you able to see my screen again? So I'm
yes.
Yeah, I'm going to put the sagittal and coronal picture of this patient. And obviously in the regular X-ray or the scout of the CT, you notice that patient has quite significant degenerative disc disease. Now I'm going to go through the sagittal and coronal pictures here. And as you see, the degenerative disc disease here is quite multi-segmental. It's not one level or another that is the problem, but the many different levels are the problem. And in this specific case, you see quite significant the calcified bone in L1, 2, spondylolisthesis in multi-level, spinal stenosis. This is a myelogram, as you notice. And as well in the coronal pictures, I'm hoping you're able to see that we are dealing with quite significant scoliosis that this patient is having, which practically, quite frankly, explains the why this patient have multi-level symptoms. Now, again, considering that this patient has maximized non-surgical treatment, now as you see here, we are as well seeing lateral listhesis and so on. So are there specific questions regarding these films or specific views you would like to see? Or do you have any, otherwise I would like to go around and ask for options about what general option, even if this patient was in excellent health, what option would we have for this patient? Does anybody have, first of all, any question regarding additional clinical information I might have missed? No? No question?
Dr. Abbasi, could you please show the myelogram picture?
The actual myelogram, or you mean these are post-myelo CT? Partly post-myelo CT shows most of the information you need. I can look for the actual myelogram, but let me see here. I'm going to take that here and X-ray. So, but this is the post-myelo CT that shows you multi-level stenosis, scoliosis, and I have as well the regular X-rays if that's of interest, but it doesn't really add much more than the post-myelo CT. So any other question regarding clinical symptoms before? And this is the other view that you see, obviously the scoliosis, multi-level disc disease, and so on. So now, obviously, so again, please feel free to ask any question you may have in the chat window or unmute yourself and ask that. Now, obviously, two other very good spine surgeons have refused the surgery, not because the patient doesn't need that. I don't believe anybody doubt that this patient has symptom corresponding to these levels, but because overall poor health status. And I think one thing that everybody needs to understand here, part of the poor status of this patient is because she has been non-ambulatory. And as we know that if you're not ambulatory, your cardiovascular system, the condition. So it is a catch, as we call it in US, catch 22. You don't know which one is came first, but at the end of the day, the poor condition aggravate the situation and the pathology because patient cannot walk. She's going down the hill, but as well, more importantly, it prevent for the patient to get care. And so generally, a regular surgery in a situation like that would be at the low thoracic to sacrum and with iliac crest, a long stretch, decompression, osteotomy, and fusion. This is practically, I would say, the regular surgery that is done for situation like this. Now, I like, maybe ask around in your experience in Iran, or generally as a spine surgeon, what option, if this patient was in a good condition, would you give to the patient? Like, if I may ask, like, I saw that Dr. Al-Talhi unmuted himself. What levels would you do even approach or do surgery if you were going to do this surgery? May I ask you, Dr. Al-Talhi, what level would be in your hand this patient candidate for? We may have some difficulty with the. So Ali, why don't you, just if this patient would be having surgery, what
Yes.
levels would you think the surgery would be appropriate for this patient?
In Iran, most of the surgery is open surgery. I think if this case in Iran, open surgery L2 to S1 approach.
No, I see Dr. Altai in the chat window is writing L1 to S1, and that's absolutely correct. With the pathology is L1 to S1, and it's almost unfortunate though. When you have a pathology that's that big, usually fixing it L1 to S1, meaning fixing where it needs fixing, even though it's the right thing to do, put too much stress on the adjacent segments. So for that reason, most of the surgeons that I have talked to, they would go, and not only to L1, they would go above, and on the bottom, they wouldn't go to S1 alone. They would as well put to go screws in S2 or additional iliac crest screws to make the structure stronger. And that is the data we have for a long time, that we know if you do a big segment surgery and if you limit yourself, especially in the elderly, especially with osteoporosis, if you limit yourself to the levels that are actually need helping, sometimes the adjacent segment, what we call PJK, proximal level kyphosis, is very high, but as well, the S1 screws are at significant higher risk of failure. And as anybody who has done significant spine surgery, about 80 to 90% of the screws that fail in your construct are S1 screws. So for that reason, lots of surgeons do go to either S2 or put iliac crest screws and so on. So And so practically that would be a lower thoracic in most of hands, lower thoracic to iliac crest, sacroiliac joint, iliac crest, and that posteriorly can be done. And most of people who do that, they may put some interbody in selected levels, but putting 5 interbody cages here would be quite excessive and long surgery. So I can just give you a statistic. When I used to do this surgery open traditional way, that would be a 8 to 10 hour surgery with 2 surgeons actually. And we would instrument like T10 to sacrum and iliac crest, me and one of my orthopedics colleagues. And our blood loss was usually about half a gallon. We would use the cell saver and we transfuse multiple units and then blood products in the surgery and so on. And now there are some additional approaches that you can do, XLIF and so on, but they will not save you any time. They may save you, somewhat blood loss that when you do the interbody, you may lose less blood in that regard, but they do not save you any time, because when you go lateral, you put the cage in, then you have to break the scraps and turn the patient back, do a second surgery. And I can just tell you, there was no way any anesthesiologist would put this patient to sleep for that kind of surgery. They literally would not approve that surgery for this patient in a poor status to go down for an 8 to 12 hour surgery with half a gallon of blood loss. I think the risk associated with anesthesia would be tremendous. Additionally, let's talk about that a little openly. What is the general risk of infection? Ali, what do you think? What is the general risk of infection in general spine, not this case? In spine in the United States, there's an acceptable risk of infection with spinal fusion. What do you guess what that risk is, Ali? Throw out a number. It's really no wrong answer here. Throw out any number you like.
30%.
Sorry, doctor, can you repeat the question again?
Say one more time.
30%?
Well, no, actually, the acceptable rate of infection for the spine for regular surgeries is 3 to 5%. But you're absolutely right. If you get to scoliosis, to this horrendous kind of correction from thoracic to sacrum and so on and so forth, the overall rate of complication, I just put a link in presentation out there by a very experienced spine surgeon. The rate of complication is 30 to 70%, but not all of that infection though, okay?
Okay.
But the acceptable, the people report easily 15, 20% risk of infection for this long construct. And that is not, so what I'm trying to get at here, the surgery is not by doing the surgery successfully. These are quite tremendously invasive procedures. And even if the surgery goes well, we are still not done. That the postoperative, infection, postoperative pulmonary events, cardiovascular events, these are
DVT.
DVT, huge rate of DVT. But again, if you go to LinkedIn to the post that I just put on LinkedIn, it's a Vumedi presentation about the surgeon that recite the literature. The risk of complication in a long construct scoliosis correction is between 30 and 70%. So this is not low by any regards. Now, I'm just going to go fast.
Dr. Abbasi,
Yes. Yes.
I think Dr. Al-Talhi want to speak.
Yes, please, go ahead.
Dr. Al-Talhi.
No, thank you. Already got it, the information. Thank you.
So now the idea to help this patient is, is there a way to reduce the trauma to the patient and reduce the blood loss, reduce the time under anesthesia, because I think something that we have to be all aware of, some surgeon tell me that the time under anesthesia doesn't matter. I couldn't disagree with that more. The time under anesthesia directly correlate with the associated complication after the surgery and during the surgery. And I mean, any anesthesiologist can tell you very clearly that a surgery that is 1 hour and a surgery that are 6 hours are not the same surgery. The risk associated are much longer. But this has been quantified. I mean, we don't really have to guess that. There are good amount of information out there that how much additional time on just on the anesthesia really adds to the combined risk of the surgery. Ali, or maybe somebody else, would somebody like to just quantify that based on the information available papers? Do we know, like, if your surgery is 1 hour longer or half an hour longer or more or less than a certain number? Does anybody want to comment on how much additional risk are we adding to patients' overall outcome? Any takers on this? Because I think this is important. Any takers? So I'm going to show you the data. This data is based on more than 400,000 patients. It's a meta-analysis of all surgeries, and it shows that every additional half an hour under anesthesia adds 17% to the combined risk of the surgery. So, and I'm going to share in the chat screen the reference with you, so you can go actually read the official original paper. So I'm copying it in the chat window, and I see that RA. So it says, do you have any consideration to stop at L1 thoracolumbar zone? Yeah, we just talked about that if I would be doing open surgery, yes, I would. I would go probably to the lower thoracic. And that is what I'm going to,
Yes. Yeah, he returned. He signed a new contract with Real Madrid, and now he's returned to them.
I apologize. I didn't understand that. So the question that says, do you have any consideration to stop on L1 thoracolumbar zone?
Yeah.
And the answer to that is, for a regular surgery we just discussed, yes, I would. The rate of maximal kyphosis.
Let's go with the boys.
Okay. Now,
Why are we not trying to get him?
I apologize. I don't understand that. Okay, so let me just continue. And again, I put the reference for this paper in the chat window. Please copy it and read it. The way the math adds up is that if you put all the surgeries below 2 hours in one group and all the surgeries above 2 hours in a different group, you're doubling the complication rate of any surgery. Now, it has only to do with anesthesia time. This has nothing to do with what kind of surgery you do. But we know in the spine surgery, when the patient is prone, the rate is even higher. This is for all surgeries. Okay. So I'm going to reduce that now, and then just show you what I did. By the way, we often talk about the patient as just a diagnosis and so on, but I want you to look at this patient, because I think it's important for us to know that each patient has an individual history, okay? This is actually the patient 4.5 months after the surgery. And what I did, and I can show you more pictures, I did a L1 to S1 fusion I put interbodies in every level. And I put the interbodies, as you see, the interbodies are, some of them are eccentric, and that's not by chance, that's by design. So we can, by putting the cage or interbodies more eccentric, we can correct the scoliosis. And that is exactly what's happening. If you compare this to the original picture, or I got a CAT scan as well, here you see that this is a very different kind of picture than the original picture that we looked at. And as well, I think it's more important, just 4.5 months later, I see inside of the disc, the bone is growing through. So we have 4.5 months after the surgery on a deconditioned patient, fusion is achieved. Now, and as well, you see here, I will come back to that. But what I think is important is that surgery wasn't 12 hours. We didn't lose a gallon of blood. This surgery was under 2 hours with a cup of coffee blood, like a 230 cc of blood loss. And what as well I think is important in this patient, that this patient was 1 month after the surgery, free of narcotic, so she didn't need any medication. And about 6 to 8 weeks after the surgery, she started ambulating independently. Considering that she was non-ambulatory for 6 months before the surgery, as you see, she's not 50 pounds anymore. She has put some weight on, and the reason my anesthesiologist let me do this surgery is because they are familiar with this kind of surgery that is not a 10-hour surgery with a gallon of blood loss. I think this is the point I'm trying to make. Now, there is a very good question, the complication like CSF leak in lumbar decompression surgery. I think that's a fantastic question that we need to answer. Now, to actually answer that first, let's consider what is the rate of CSF leak, which we call durotomy, when you cut through the dura. I mean, every spine surgeon knows when you are doing your decompression, sometimes you catch on the dura, sometimes there's a scar, and you have CSF leak. Sometimes even the nerve roots, like a spaghetti, they come out and they add significantly to morbidity, mortality, and complication of the surgery. But let's ask the question, what is the accepted or what is the reported rate of durotomy, CSF leak, in a spinal fusion? Any takers? I'll throw it out.
1 to 17%.
Yes, that's very good. The average is reported is 7.8%. Some studies say 1%, some studies say 18%, but if you average them all out, it's about 7 to 8% risk of durotomy, which makes sense. In the bigger surgeries, like 5-level surgeries, obviously your risk is not 1%, it's much higher. And in a 1 level, it shouldn't be like 17%. But generally, 7 to 8% is accepted risk of the durotomy or CSF leak. Now, before I answer what is the rate of durotomy in the minimal invasive transcambine OLEF, by the way, for everybody, everybody who doesn't know that the transcambine approach has been described by Dr. Parviz Kambin, who was a Persian in 70s and 80s in Philadelphia, who described the Kambin triangle and Kambin approach. He just unfortunately passed away a few years back, but I had a really pleasure and honor to meet him before he passed away. And he was such a humble and a good son of Iran, and he still has kept it, all the good habits that we have. And he even went to his home, and a few years back, I published my discussion with him online. So this transcambine approach has been described for 10 years. Why am I describing it to you? Because I want to show you what that approach looked like and tell you why, after 1,500 cases, I have not had a single durotomy in my patient population. And the reason for that is anatomy. Look at that. When you go posteriorly, PLF and TLF, you take the muscles away, and then you do a laminectomy, and then practically you are manipulating with sharp instrument around dura. Whereas in a transcambina approach, you are far, far away from the dura. So it makes sense that my rate of durotomy is 0. I have to be very, very wrong in a very wrong place to get a durotomy. And knock on the wood, I have not had a single durotomy after 1,500 cases and 10 years of doing this procedure. So now let's go back.
Dr. Abbasi, I have a question.
Yes.
What is the rate of ALF in the olive transcombine?
What do you mean by ALF?
Adjunct level fracture.
So or what we call we call that proximal
Adjunct segment.
Yeah, fracture. Now that rate, and that is another question, I think very legitimate question. Do I need to go in a surgery like that? I'm sure you are able to see my screen now, correct?
Yes.
Now, do I need to go? We talked about that when we started, that most of people do go few levels up to spread the load. And in the olive procedure, do I need to do that? And or better question, why is it that the adjacent level fracture which lead to kyphosis, we call that PJK, proximal level kyphosis. Now, proximal level kyphosis is because you have a proximal level fracture and disc disease, and then leads to additional problem levels above and below. But in a case like that, obviously, there are not much level below. You're mostly talking the level above. So why do we have so many problems there? And that rate has been as well in a long construct. If you don't go all the way up, that has been described up to 30-35%. But let's go back to the basic. Why do we have so much problem with the proximal level fracture, kyphosis, and so on? Now let's talk about how we do a surgery like that, right? I think it all comes back to anatomy. In a regular surgery like this, we literally strip the muscle off the bone. Practically, if we go the traditional way, we go all the way to the what we call lateral gutter or transverse process. We strip the muscle. Now, Ali John, what do you think? Which of those muscles that we strip off the bone, which of those muscles do we go and reattach back? None of them. 0. Because we take the bone away. We cut the bone that this muscle attach, we take them away. Another thing is that we literally burn the periosteum and cut the lamina away. And the question is, what happened to these muscles after we are done? Any takers? Anybody want to tell us what happens to this muscle after we do the surgery? They turn to scar, right? This is what it is. 2-level TLF. And 6 months later, if you ever have to go back, 6 months later, if you ever have to go back, it's not muscle anymore, it's scar, it's pure scar. So this patient I did in 2012, 2-level TLF. In 2014, adjacent segment OLF. In 2015, patient had an accident. I had to take the patient back to surgery because he broke hardware bone after a car accident. And that is how I took this picture, where I did the TLF scar, where I did the OLF pristine tissue. Why is it important? Let me show you how it looked like in MRI. In MRI, you see this tissue after the fusion is not muscle anymore, this scar. Muscle look like that, but more importantly, this is a L4-5 TLF. In L4-5 TLF, even 2 levels above it, not one level, but 2 levels above it, the multifidus muscle turns into scar. It dies. And let's talk about that. Why is it important what happened to the muscle 2 levels above? Now, the answer to that is laid again in anatomy. This is a study from 1930s, 1935, 1937. There is no artery of L4 or L5, correct? The vascularization of all our bones is through surrounding muscles. And when you strip the muscle of the bone, you are removing all the vascularization of the bone. And as you just saw here, even 2 levels above. So what does that mean? In a regular surgery, you're stripping the muscle, you're killing all those muscles, you're turning them into scar, which is avascular. As a matter of fact, the studies are very clear about that. When you do a posterior fusion with going all the way to the lateral gutter, you're removing 75% of the vascularization of the bone, even 1 or 2 levels above. Now, it makes sense why our observation holds that literally you have a huge adjacent segment problem if you stop at L1. So always go higher. And that as well explains why in my surgery, I don't have that bad result. Your question was, what is the rate of adjacent segment fracture and kyphosis? That is extremely low, like 0.5%, because I'm not destabilizing all the levels above, and I can show based on my data, they fuse, the stress level is maybe not different, but those bones are well vascularized. I didn't remove 75% of the vascularization of those bones. That's why I can afford for my patient group to go just to the level of the pathology and not 3-4 level above it, like regular surgery would ask me or require me to do. So, but coming back again, always center back to the patient, to this individual patient. So about 4.5 months after the surgery, this patient is off narcotic, bone is fused, and the patient is off narcotic, regained weight, and this patient practically has regained the life in a surgery that in open surgery would be quite impossible. So, and that summarized the advantage of transcambing OLEF compared to the open old-fashioned surgery. The fact that even in younger patients, you ambulate them within hours and you send them home. I just did in my surgery center here in Minneapolis. I did a 3-level fusion and I sent that patient home just 2 hours after the surgery. And you're able to, to provide that consistency, but the true value of transcambing OLEF comes in the patient like this one, that the open surgery is not even a possibility. It's not even possible to provide this surgery. Now, I put these pictures up there on internet, and somebody asked me about, what about the lordosis? And let's talk openly about lordosis. I'm sure all of you have heard that there is a huge discussion, and it's almost fashionable talk about lordosis and how are we correcting the lordosis. I totally see that I did not restore the lordosis on this patient. I see that. But let's talk about the lordosis. There is a huge body of the evidence, and if you are interested in that, my colleague, Dr. Sunny Kim, who is a 35 years scoliosis surgeon, made a video about that he explains that. Now, based on lots of information on the original scoliosis data, which is mostly juvenile and younger people, and long stretch fusion, we know if you don't correct the scoliosis, correct the lordosis, patients have long-term, they may have additional problem. The outcome is not the best if you don't correct the lordosis. And those data are valid. We understand that but we have to pay attention as well about where is that data produced. That data is produced in traditional scoliosis cases where you have young patients who are going to live 50 years. In long stretched fusion like thoracic to sacrum, and more importantly, for open surgeries where you do all the damage we talked about. Now, unfortunately, lots of surgeons, most of them less experienced, they think they can just take those data and transfer it one-to-one to the 2 or 3 level fusion on a 70-year-old person who is not going to live 50 years. And that sort of has made a kind of situation in the United States that you see these doctors, they look at the film and then they say what kind of surgery they have to do to correct the lordosis. And they concentrate on correction of the lordosis and the deformity parameter with the data which is inappropriately transferred from one group of patient to another group of patient. These patients are not going to live 50 years. You are not doing T5 to S1 fusion. And more importantly, you are not devascularizing entire block of spine, so they don't behave the same way. And I have 10 years of data to show that. Now, more importantly, I don't believe this patient really cares what the spinal parameters are. She has regained her life, and the open surgery wasn't even an option. But when I put this out there, now some knee-jerk reaction of some surgeon is, what about the lordosis? Now, the fact is, if you listen to Dr. Sonny Kim's talk about how this parameter come to be, in a 1 and 2 level degenerative, even 4 level degenerative scoliosis, in an elderly, those parameters are not powerful at all. They're literally, if you try to correct those parameters in a 1 and 2 level, the amount of the bone work you have to do like a wedge resection of the vertebral body. Even worse, some surgeons decide, instead of doing like a 3-level fusion, they decide to do a 8-level fusion to correct. They make a bigger surgery so they can correct the number. And there's 2 situations. This is a patient that cannot have 8-level surgery, and then they tell the patient, go live with it. Most of these patients don't live with it. They go and die with this problem. And some other younger or healthier patient, instead of getting a 3-level fusion, they get a 7 and 8-level fusion just to correct that number. So let's coming back, and I want to show you a few slides in my OLIF presentation. And we have been now, I'm planning to maybe continue 5 to 7 more minutes and then take some questions. So if you have questions, please type it in. I see that herniated disc surgery will develop paralysis. Any chance? Well, absolutely. There is a significant risk of nerve damage in any kind of spine surgery. But as soon as I show some of my slides, I will come back to that and talk about the complication rate, some of which we talked about with like a durotomy, in open versus MIS transcambine MIS surgery. But there are a few more slides I want to share with you. And by the way, if you're interested, this is a list of all our papers, and I'm going to put it on the chat window. Please feel free to copy it so you can go online and read them. But more or less, what we have been able to do, we have been able to do spinal fusion a day surgery and ambulatory surgery, because about 95% of our surgeries are under 2 hours, skin to skin. And that enables us to do many of these surgeries actually in an ambulatory center. The patient comes, we do the surgery, patient goes home same day. That's what it is. Now, we talked, I want to show you maybe a few more slides. One of the factors that is very important for taking care of this kind of patient is BMI, especially in the United States. The BMI is there's epidemic high BMI in the United States, and many of these patients with high BMI, they don't get the care they need because our societies, meanwhile, they don't recommend to do a spinal fusion routinely for BMI above 40. Because exactly what we talked about. Look at that. This is one hospital, entire fusion of that hospital. The blue is the time on the anesthesia. And if the BMI goes up, time on the anesthesia goes up. And literally, these surgeries become exponentially more complicated. MIS-TLIF in the hand of a star MIS-TLIF surgeon who has done 2,500 of these is still start good, but at BMI of 37, it becomes even riskier than open surgery. But transcambin OLIF stays flat. Literally, we can do that surgery on BMI of 22 and 45. And a second study showed even on BMI of 60, we can perform this surgery very safely. 96% of these patients ambulate in the first 24 hours. That is why they are able to go home mostly within a day. And now let's talk about risk associated with this surgery or any spinal surgery. But let's not limit ourselves to risk of nerve damage, but start with basic thing, blood loss. The blood loss we found to be in the transcambin OLIF 1/10 of the open surgery, meaning most of the time our blood loss is in tens of cc's. We literally don't use a Bovie, bipolar, or suction. We use sponges to suck the blood, and after we are done, we measure the dry and wet weight of the sponges and calculate our blood loss. Like in this patient that I just showed you, our blood loss was 230 cc, which is a cup of coffee, if you want to have a comparison. Additionally, obviously this surgery technically is challenging. There's no question about that. This is a challenging, technically challenging surgery, but once you go through a learning curve, it's no different than any other surgery. There's a series of specialized tools used for this surgery, and I can guarantee you, I'm always asked, can you do discectomy? Can you prepare the end plate? I can guarantee you after 10 years and doing 1,500 cases, I can tell you for sure, anything you can, any kind of disc you can remove with traditional surgery, I can remove through this procedure with these specialized tools. You can put the cage right and left, front and back, correct for both sagittal and coronal deformities, and the fusion happens much faster. And that makes sense. Again, as we discussed, you're not removing the vascular supply. One last picture I do like to show you is that, that about the complication rate. Let me go back to, again, these are charts regarding the patient outcome. This is part of our paper that it shows clinical outcome after a year. It's online. You can, and I put the link to that up in the chat window. Please copy that. Once we close the window, all those information are gone. So if you are going to copy it, please do it now. So let's talk about the risk associated with surgeries. We talked about the risk of durotomy. We talked about the risk of infection, which is in our cohort is 0.3%. I had only 3 superficial infection in 1,500 cases. None of them required return to surgery. So no incision and drain in 1,500 cases. Though all those 3 superficial infection, they were in extraordinarily unhealthy patient, and they all responded to 5 days of Keflex. But let's talk about other risk associated with surgery, including nerve irritation, nerve damage, weakness. That was the question. I have done extensive research on that, but the data for traditional surgery is out there. There are lots of papers discussing the risk of nerve injury. What is common in all those papers, they never talk about the early complication. They always talk about late complication, mostly 6 months to a year. And that number, Ali, I would love to ask you one more time, just guess what you think, what is the rate of nerve injury after TLIF, PLIF, in what is reported 6 months to a year? What do you think?
I think it should range from 10% to 20%.
You're very good on that, but the literature again has a huge range. Okay. Now, and again, if you're interested, I can send you but this is the literature research. Everybody should be able to do that. In the literature, it has been reported 1% to 35%. Like if you do XLIF, especially in 4-5, your risk of nerve irritation, nerve damage is much, much higher in 4-5. Okay, but in average, for most uncomplicated cases, it's about 1 to 5%, about 3% seems to be the average 1 year risk of permanent damage after our surgeries. What is important is all those studies that I have looked at, if it is, there are some studies that shows it's 1% or less, but those studies are very few number, like 10 patient, 20 patient in a hand of one surgeon, very experienced, low BMI and so on. But in average, you should consider it about 3%. Now, but all the results never talk about early results, all talk about 6 month to a year results. Now, I can just recite you my rates, okay? Initially, with my learning curve, and I'm going to show you a picture here. This is the rate of all complication, but as well neuropraxia, nerve irritation. Now, this is early result. This is not the long-term results, okay? Meaning that
in which months of follow-up?
This is like right after the surgery, a week after the surgery, okay? 1 week to 3 weeks after the surgery, okay? This is like patient wakes up and has numbness on the top of the left foot. This is not being paralyzed or anything. This is just patient having any symptoms at all after the surgery, okay? Now, what's important, I compared, most of if you have done TLIF, next day after the surgery, you see the patient with the TLIF, numbness in the feet is not what that patient is complaining about. Patient cannot move from side to side. Patient cannot sit. Patient cannot get comfortable. So this patient never talk about those minor findings. But once we look at that systematically, that literally going to the patient and examining all segments and find out the rate actually postoperative follow-ups, it's accumulate. This is just one cohort, but if I put all the cohorts together, the rate of initial, meaning a week to 3 weeks after the surgery, culminate down to about 12 to 15%. The rate of the OLIF is actually a little lower than that, but once we follow them up a year, most of this get better after 1 to 2 months. So contrary to lots of other studies, you got the early results and you got the later result, but more importantly as well, what we did, we went to those TLIF patients and we examined them very accurately. So even though they don't talk about it, the problem with that OLIF patient is they're ready to go home and they ask you about, why is my toe numb on the left side? But that patient with the TLIF is 1 week in the hospital, never complained about that because that's not his problem. The problem is that he has pain 10 of 10 and he still cannot sit to go to bathroom. Once you systematically look into that, the rate of early nerve irritation is about 3 to 5% less. And now I'm going to show you the long-term results. In the long-term results, only one patient in 303 patients had still neuropraxia, and 4 patients had nerve irritation that was clinically not relevant, meaning that the left foot is still numb, but they go about their days. It doesn't limit their daily activity. So 1% permanent damage, 1 patient in 303 permanent damage, which make that rate 0.3%. So we have a very good question about the amount of the X-rays we get, amount of the radiation exposure in the OR, and I'm going to answer that now. Obviously, that here, as you see, the fluoro time for this surgery is going to be higher because you get a lot of X-ray, AP, and lateral. And as if you remember, the setup in the surgery, you have 2 C-arm, 1 lateral, 1 AP. So the result is going to be that you get more X-rays. And that we have quantified. As a matter of fact, there is a study right now running to get actual dosimetry, but I can give you some insight on that as well. When I started that, my first patient, I needed 4.5 minutes X-ray time. 4.5 minutes. Let's put it in perspective. Ali, I think I'm going to ask you one more time. You have answered the question very greatly so far. Now,
Thank you so
tell
much.
me, when you get a cardiac angiogram, how many minutes of X-rays do you think patient gets in a cardiac angiogram? Cardiac catheterization. Yes.
More than 1 hour.
Well, actually, we are pretty good. About 40 minutes. About 40 minutes. In a cerebral angiogram, that number is about 22 minutes. So for a one-level fusion, 4.5 minutes is not very high. But more importantly, that is my first case. After you have gone through learning curve, that number comes down to 90 to 120 seconds, meaning 1.5 to 2 minutes, because you're not getting fluoro, you are getting just a static X-rays. Now, if you are very interested in understanding what that really means overall, what is the surgeon volume? So practically, you're getting much less than an interventional cardiologist or cerebral angiogram interventionalist. So your risk associated are significantly, very significantly lower. But I want to show you something else, actually. I want to show you, if you're interested in true dosimetry of that, I have an album in my blog on Facebook that calculates these numbers for you. Now, there's a huge difference in the devices in the CR machines that have been produced before 1990 and after. And there is another huge difference in the machines that have been built since 2005. And that is about the technology. In the images that in the machines that they were in 1970s and 80s, early 80s, the radiation was like 100 to 150 times more than after, because they start having these so-called intensifiers, where it's a machine, it's a layer of films that are already charged, and when the X-ray hits that, 1 photon becomes 2, becomes 3, becomes 4, and then it gets more and more. So you could intensify practically that 100-fold, 150-fold. By the way, anybody knows about the nighttime goggles, right? Where you in dark, you see well. Those cameras that in the night give you vision, they work the same way. You have an intensifier. A photon hits, 1 photon produces 2 photons. Those 2 photons produce 4 photons. Those 4 photons produce 8 photons. So we start using them in 1990s, and our radiation levels sank significantly. Another big finding, another big thing was in about 2000, where we had this high resolution, high the accuracy and precision chips that they would see a single photon and identify it so much better. So practically in the United States right now, if you are 6 feet, meaning 2 meters, that's all you need. If you're 2 meters away from an X-ray machine, you do not need any X-ray apron. You do not need any lead if you are literally 2 meters, 6 feet away from the X-ray machine. The importance of that is significant for us spine surgeon, because that will reduce the risk for us. Okay, patient as well is important as well for the patient, but patient may get 1 or 2 surgery, and that risk is quite low for the patient. And what I'm trying to tell you, in 2023, at least with the technologies available today, the amount of the X-ray radiation that I get as spine surgeon is very similar to a pilot that flies over the cloud 10,000 meters and get lots of cosmic radiation. My exposure to radiation is very similar. And if you are truly interested in actual numbers, how those numbers come to be, what that means, and even some tips about how to mitigate that, like how to take more information from those, go to my blog. If you go to facebook.com Abbasi NSGY, go to my albums. One of the albums is exactly that, radiation. And here you see radiation safety. You see that album? If you go to that album, it goes over all the numbers, all the information relevant, and it tells you, calculates for you how those numbers come to be and why certain setup in the war is better than the others, and why, based on the current kind of devices we have, that is not my main concern anymore, because again, we are not using devices, X-ray machine from 1980s. And this is, you see the cones of radiation. And if you are 6 feet, not meters, 6 feet, meaning 2 meters away, the radiation dose that you get is so low that you don't even need to have put lead on. Now, if I'm not sure if any of you guys are old enough to know that we used to put lead in the wall of the war. If we were going to shoot X-ray, we had to put literally lead in the wall. We don't do that anymore because the machines, they produce so little radiation that they don't require anymore to put any lead or blocking material in the walls of the war or your CT machine. And so if you're interested, please go to that blog and read about that. Now, I'm going to stop here and start, maybe answering some question you may have, but please feel free as well, connect to me. I'm going to write my email here. I'm very interested to bring this technology to Iran. It's still my home country. This is my email address. I'm writing in the chat window. It's Abbasi inspiredspine.org. Please connect to me if you have any question. We have labs. I have a lab coming up in Hamburg on July 3rd. And we are going to start podcasting some of our surgery directly from our surgery center worldwide. We have every first Saturday of the month, we have case conferences. If you have a difficult case, please come and join us. We are happy to go over them and answer them. I apologize if we have some technical difficulty and I couldn't answer all your questions, but I will put a copy of this talk. I will put a copy online, and then you can watch it back. And certainly, you are all welcome to come to one of our centers for a visit, for observation. Connect to Amanda Armagos, and I'm going to write as well her email here, aarmagos@islife.com. www.ecom.us. And she can help you with our curriculum and labs and dates and so on. But I'm open for any question if you may have. Otherwise, it is 1:10 my time, and I'm assuming it's about what 10:40 your time, Ali. Is that correct?
Yes.
Okay, you have not
Uh,
enough time.
9:40 because
9:40.
times
Oh,
yes.
okay. So that it has changed. You don't have summertime and wintertime anymore.
Yes.
I see.
Governmental decision.
Yes.
Yes.
Well, it has been really my pleasure, having you all online and go over these issues with you. And I will put a copy of this meeting online for everybody. But if you have any additional question, I would say I would take few questions.
I will share the Google Form link for your any recommendation for further webinars. Me and Dr. Abbasi will be very happy to hear them.
So, and again, if you are more interested, it has been my pleasure to talk to you. Iran is still my home, and I'm hoping to come to Iran and maybe perform some surgeries and literally bring the technology in. Please connect to me if you have any other question or you want come and visit us. And I hear a question: do you intend to open an annulus contralateral, and how? That's a very good question. If when I put the cage in, I put the cage in on the right or the left based on what it needs to be. With some experience, the cage actually can be inserted right or left and open both or in the middle. But what I have noticed, and that is something I really like you to go and look up, and I think I will conclude that with this, and that sort of help us to really understand that. What I'm doing right now, I'm going to OLIF, I'm going to YouTube, and I'm going to just put OLLIF. And if you go there, you literally, not figuratively, you will see, if you come down and start patient testimonials, I have put over 1,000 patient testimonials. They all tell that they wake up and the leg pain is gone. They wake up, the symptom of radiculopathy and stenosis are gone. And even though I don't cut the bone, and the question is, if I open up the annulus, practically you're asking me if I'm doing foraminal decompression on the opposite side. The answer to that is, by putting the cage right or left or in the middle, I can control how much elevation I get in that space, and that literally relieve the stenotic symptoms of the stenosis. Again, what that really means for a patient is that patient wakes up and the leg pain is gone. Now, I want to show you, if you go to YouTube, put impossible OLIF. I put, just so you find it better, I put that word impossible OLIF. Look at this one. Patient has a scoliosis, and I entered the osteophyte and lifted up, and I put the cage very eccentrically because I really want to open up this side and correct for the scoliosis. Now look at these osteophytes here and compare them. What happens after the cage is in? And you see that there, when the cage is entered here, look at the difference between this space here and this space before. Now I can just tell you, if I wanted to go and control the otherwise, I always go from the left. But in some cases, you will see I put the cage completely to the other side. As the case that we just discussed, at the beginning, the cage was on the right side, and that is how I do that without opening really the annulus, by placing the cage strategically. I have another question. What about endoscopic surgery and endoscopic? No, let's put it this way. Endoscope has a huge value, especially, as a matter of fact, Dr. Kambin we can be proud. Dr. Parviz Kambin started the endoscopy in the spine. He used the regular endoscope of the urologist to use that for this procedure. And especially the value of the endoscope, if you do it the Kambin way, meaning in retroperitoneal spacing through the Kambin triangle. Because doing the interlaminar endoscopy, we have been doing it already. We're doing microscope instead of endoscope. Now, why is it important? Because endoscope, you are holding the endoscope with one hand and you're operating with one hand only. And as well, with the endoscope, you have a 2D view, whereas with the microscope, I have a 3D view with two hands. And more importantly, is that the size of the tube in the endoscope is maybe 8 millimeter or 10 millimeter. In macroscope is 18 millimeter. I use 16 and 18 millimeter tube all the time. So 8 millimeter tube or 18 millimeter tube, it really doesn't make a clinical difference, except if you use it for extraforaminal transcampine approach. Macroscope and the tools are not good for that long of a throw. Endoscope is perfect for that. So the endoscope has a huge value. I used it few times for my surgery, but it didn't really give me any value. As soon as you put it in, there is smoke, there is blood, and it adds 2 hours to the surgery without really giving me any additional value. So I stopped using it for my olive procedures. So